Hi guys, welcome back to Fertility Friday. Today we'll be talking about endometriosis. Endometriosis is a condition where the cells that line the inside of your uterus, called the endometrium, grow outside the uterus. The lining of the uterus, or endometrium, responds to the cyclic hormonal changes in your cycle and shed once a month, resulting in a period. With endometriosis, endometrial cells can grow elsewhere, such as in the ovary, the tubes, the uterine muscle, or other places in the pelvis, causing cysts or scar tissue. Most patients will present with severe pain with their periods, pain with intercourse, sometimes pain with urination or bowel movements, or infertility. Symptoms do not always correlate with the severity of the disease, and patients can be asymptomatic and still have severe disease. Several mechanisms have been proposed for how endometriosis occurs. 1. Retrograde menstruation, where endometrial cells backtrack through the tubes and into the pelvis. 2. Spontaneous changes in the cells that line the pelvis. 3. Direct transplantation, for example, after a C-section, where endometrial tissue may end up in the abdominal scar, creating endometriosis in the abdominal scar. Or 4, vascular dissemination, which refers to cells traveling through the vascular system. It has been suggested that there may be a link between endometriosis and an impaired immune system, and that increases in immune cells in the pelvis may promote the disease. Endometriosis also acts differently than normal endometrial cells in the lining of the uterus. Endometriosis cells are associated with higher local estrogen production, higher prostaglandin production, and being more resistant to progesterone. Endometriosis is thought to be associated with infertility by a few different mechanisms. 1, potentially causing adhesions and distorting pelvic anatomy, and this can impair the release of the egg from the ovary. It can inhibit the egg's ability to be picked up by the tube. It can inhibit transport through the tube, and endometriosis can also result in tubal blockage. 2, an inflammatory state in the pelvis. This inflammatory state may have adverse effects on the eggs, the sperm, embryos, or tubal function. 3, there may be changes in the endometrium itself, which can alter endometrial receptivity and endometrial implantation. 4, cycle dynamics and ovulation abnormalities, such as abnormal follicle growth, longer follicular phase, ovulation dysfunction, or luteal phase dysfunction. And 5, endometriosis can be associated with decrease in egg and embryo quality. The only way to definitively diagnose endometriosis is with surgery. When addressing whether or not to perform surgery on a woman with infertility and endometriosis, this is a complex question, and one needs to consider the likelihood of the diagnosis of endometriosis and the potential benefit of treatment. Laparoscopy used to be standard as part of the workup for infertility, but this is no longer the case, as benefit from surgery in women with mild disease is minimal. There are certain findings on history, physical exam, or ultrasound that can be suggestive of endometriosis. On history, patients often present with cyclic or chronic pelvic pain, dysmenorrhea, which is pain with periods, dyspareunia, or pain with intercourse, or pain with urination or bowel movements. On physical exam, endometriosis patients can often have a fixed retroverted uterus where the uterus points toward the rectum, adnexal mass, or uterosacral ligament thickening or tenderness. On ultrasound, endometriosis can be presumptively diagnosed if an endometrioma is present, but ultrasound or MRI will not be able to pick up small implants in the pelvis, and thus these diagnostic tools will not always be able to diagnose endometriosis. A staging system has been proposed to allow us to communicate the extent of the disease and also for research purposes. ASRM's classification system for endometriosis is the most commonly used staging system. However, there are limitations to it as it poorly correlates to pregnancy rates. There are overall 4 stages: minimal disease, which is isolated superficial disease on the peritoneal surfaces, mild disease, which is scattered superficial disease, less than 5 centimeters in total, moderate disease, which is multifocal disease, and there could be adhesions also present, and severe disease, which is multifocal, has potentially large endometriomas and adhesions present. Treatment depends on if the primary goal is to treat pain or infertility. Let's start with treating pain associated with endometriosis. For women with pelvic pain, suspected endometriosis, and no indication for surgery, these patients can be first treated with medical management without establishing the diagnosis surgically. Treatment options generally include NSAIDs, birth control pills, progesterone, danazol, GnRH agonists such as Lupron, and aromatase inhibitors. For mild symptoms, treatment usually starts with NSAIDs and birth control pills. Medical treatment is commonly used to relieve pain associated with endometriosis, but medical management has not been shown to improve fertility. This is primarily because medical management for endometriosis typically involves suppressing ovulation or the release of the egg. Treatment for endometriosis and infertility is complex. For stage 1 or 2 endometriosis, surgery has been shown to be associated with small improvements in live birth rates. 2 randomized controlled trials have evaluated how effective laparoscopic surgery was, and only one study showed a benefit. When the results of the study were combined, the findings showed a benefit of surgery when the number needed to treat was 12, meaning for every 12 patients having endometriosis at time of laparoscopy, there was 1 additional successful pregnancy if endometriosis was treated surgically versus no treatment. However, a certain number of asymptomatic unexplained infertility patients may also have endometriosis. If we include this group, the number of laparoscopies needed to gain 1 additional pregnancy is actually closer to 40. For cases of severe endometriosis, there is some evidence that surgery may improve fertility, but there are also risks. Risks with surgery include bleeding, infection, and damage to nearby organs, and there is also risk of decreasing ovarian reserve if cysts are removed from the ovaries. If a patient has already had surgery for endometriosis for infertility, additional surgeries rarely help improve fertility outcomes, and patients should consider other fertility treatment options such as IVF. Sometimes pre- or post-operative medical treatment is thought to be advantageous combined with surgery. However, there hasn't been any evidence that this will help fertility, and it may result in an unnecessary time delay to fertility treatment. The impact of endometriomas, which are cysts on the ovaries due to endometriosis, on IVF outcomes has been controversial. Benefits of removing them are ease of retrieving eggs at egg retrieval, obtaining pathologic diagnosis of the cyst, and avoiding contamination of follicular fluid with endometrial content. Disadvantages of removing them are complications with surgery and potentially decreasing ovarian reserve. Currently, surgery does not improve the benefits in asymptomatic women with endometriomas prior to IVF. However, there are no studies that have looked at the size of the endometrioma on outcomes. Therefore, the benefits and risks should be balanced by the physician on a case-by-case basis. In summary, many factors must be considered to decide treatment in patients with endometriosis, such as the woman's age, her ovarian reserve, the infertility duration, pelvic pain, and stage of endometriosis. Female age and ovarian reserve are particularly important factors to consider when planning treatment, and in older women over the age of 35, there may be a decline in fertility due to the additive effects of both endometriosis and age, and more aggressive treatment is warranted either with IUI or IVF. The benefit of surgery for minimal or mild disease is really insufficient to recommend surgery alone to increase the chances of pregnancy. In young women with stage 1 or 2 disease, IUI can be considered a first-line treatment option. For women over the age of 35, more aggressive treatment options such as IUI or IVF may be considered. For stage 3 or 4 disease, conservative surgery or IVF are recommended. If a patient has already had previous surgery for infertility or because of advanced age, IVF is a reasonable treatment option. There is insufficient evidence to recommend removal of an asymptomatic endometrioma prior to undergoing IVF. However, if the endometrioma is above 4 centimeters, surgery can be considered for pathologic diagnosis and to improve access to the eggs at egg retrieval. But the patient should be also counseled on risk of decreasing ovarian reserve and decreasing response to stimulation. And the decision should be made on a case-by-case basis after discussing risks and benefits. Hey guys, thanks for watching. I hope you found the information helpful. You can always send me comments or questions here, and also send me ideas on new topics. I would love that. Don't forget, you can always follow me on Facebook, Instagram, YouTube, or TikTok under the handle A New Kathiresan MD. Thanks again, and see you next time.